हेलो गुड मॉर्निंग एवरीवन, आई एम डॉक्टर अंकुश मल्होत्रा फ्रॉम एनेस्थीसिया ब्लूप्रिंट्स। तो आजकल करा के एमसीक्यू दी कल मैं पाया सी स्टोरी थे विद इन नॉर्मल लिमिट 89 हार्ट रेट एंड ब्लड प्रेशर ऑफ 112 and 68, बट SpO2, see SpO2 is 88%, so there is hypoxia and pH 7.2. so what does mean? Acidosis. So if we see PCO2, it is rising, increase 60, normal is 40, normal, so 60 is rising, so we can say respiratory acidosis. So what is the reason behind this? So let's take what is the problem with obesity? Obesity, there is mass loading of thoracic and abdominal components of the chest wall in supine position and also in awake obese patients. So what are the lung volume which are affected in obesity? Lung volumes, FRC decreased, so functional residual capacity is decreased, ERV also decreased, expiratory reserve volume expiratory reserve volume are decreased, and total lung capacity also decreased, but residual volume there is no change. Closing capacity, no change. So only these three volumes decrease, so should be one of this volume. So let's see what happened during obesity and what happened in the normal patients. So let's see this graph, lung volumes. So in the normal patients, what happened in the normal patient? These are tidal volume 500 ml. So what is FRC? FR is a volume in the lung where respiration begins. So this is FRC. This volume is FRC. So this is the normal in healthy individual. These are tidal volume. This is inspiration and expiration. The normal patient is generating normal tidal volume above the FRC. So this is the closing volume. Dotted line, you see dotted line. This is closing volume. What does it mean? If these tidal volumes comes here, patient start breathing here. So what does it mean? Patient is breathing below the FRC. FRC is here. Patient is breathing here. So naturally FRC is decreased. If FRC decreased, patient start breathing here at this point. So at normal breathing, patient's alveoli will start collapsing at this point of lung volume. Patient's alveoli will start closing. So atelectasis will occur. So in obese awake patient, so generally they breathe here at this point, which is again FRC is decreased, and this is FRC. Patient is breathing at this point, so alveoli will close. But when anesthesia is given to obese patient, so FRC is further decreased. So now see these tidal volume. Patient is breathing. So let me rub this. So now see this, FRC further decreased, FRC under anesthesia. So in obese patient under anesthesia, see this, FRC further decreased. This is FRC further decreased. So patient is breathing below the closing volume. So patient's alveoli closed as patient is breathing below closing volume. What is closing volume? This is closing volume. Patient is breathing here in this area. If patient is breathing here, no collapse. Patient is breathing here, partially collapsed. Here some alveoli fully closed. What will happen? Atelectasis. no effective lung volume for exchange of gases. So normally alveoli are like this, but with the decreased FRC, alveoli will be like this. So there is no effective membrane for exchange of gases. So there is no gas exchange, So VQ mismatch will be there. Right to left shunting will be there, and arterial hypoxemia will be there. Actually, due to decreased FRC, alveoli collapsed as patient is breathing below the FRC and below the closing volume. Atelectasis, VQ mismatch, right to left shunt, arterial hypoxemia, air trapping will occur. Everything will lead to decrease PaO2 and increase PCO2. So in this case, same is happening. See, what is PCO2 is 60 and PO2 is 56. So finally, increasing PCO2 will lead to respiratory acidosis. So due to alveolar gas equation, increasing PCO2 is inversely proportional to PaO2. Increasing PCO2 will lead to hypoxia. So in entire MCQ, what are they saying? They have started morphine post-operatively, which is a respiratory depressant. In obese patient with OSA signs and symptoms, started morphine. So respiratory system will depressed, lead to complications. So in this entire game, if we start mechanical ventilation, so in this case, to improve respiratory acidosis and hypoxia, start mechanical ventilation. So main thing we have observed here, किस चीज़ का प्रॉब्लम बेसिकली एफआरसी डिक्रीज, सो एटलेक्टेसिस इज हैपनिंग, एटलेक्टेसिस हो रहा है तो उसकी वजह से एयर PQ मिसमैच हो रहा है, हाइपोक्सिया हो रहा है. सो इफ वी इम्प्रूव एफआरसी, if you target FRC with invasive or non-invasive mechanical ventilation, respiratory gases means hypoxia will improve, PCO2 will decrease, PO2 will increase, atelectasis improves, the recruitment of alveoli will happen, and patient's work of breathing, respiratory efforts will be normalized. During atelectasis लंग मतलब मीन्स जैसे एक लिफाफा होता है, एक फुल लिफाफा या एक बैलून होता है, बैलून में हवा होती है तो वो फुल इन्फ्लेटेड होता है, तो जैसे उसमें हवा निकल जाती है तो एकदम से मुरझाया सा हो जाता है, तो उस जस्ट लाइक दिस, ठीक है। तो इन्फ्लेटेड लंग इज लाइक दिस। तो इसको ओपन करने में ज़्यादा प्रॉब्लम नहीं आती, बट इसको ओपन करना है तो ज़्यादा एनर्जी, वर्क ऑफ ब्रीदिंग विल इंक्रीज एंड रेस्पिरेटरी रेट, रेस्पिरेटरी एफर्ट्स will increase. So what is our answer? So in this answer we have to see functional residual capacity. Mechanical ventilation will target this volume to improve respiratory complications. Thank you so much. Stay tuned with Anaesthesia Blueprints for more updates. Keep watching my stories and follow my YouTube channel Anaesthesia Blueprints. Thank you so much.